one of the interesting things that we all heard that was a common theme among these panelists was the concept of incorporating user input, which is something that most architects and most organizations take into account when they're designing facilities at this point, but perhaps we saw a new level of richness with the thought that goes into that in terms of using simulations and observational techniques to really understand what's happening rather than just asking people what they think. I think everybody also spoke to the concept of looking at different types of tools, at different types of processes, or perhaps using the same tool throughout the process, but most importantly, that there is an increasing level of detail that needs to be considered. So Jonas, for example, looked at this medication cart. Well, imagine if you just stopped thinking about patient safety during the concept design and didn't take into account some of these things as they start to evolve into more detail. So with some of those common themes, I'll open it up. I certainly have some questions I'd like to ask, but if anybody has a question that they'd like to start with, feel free. Anybody? Yes.
I actually have three, but I'll pick one. I thought Bill brought up a good point, and I applaud all the presentations because they, like I said, I have more questions than I probably have time to answer. But the issue about balancing all the things when you're creating a work of architecture or product design or anything like that, there's always a lot of forces. So I would argue that, I heard some comment about creating a separate chapter in the guidelines for safety. Well, the reality is the guidelines is about safety. Its underlying mission is about safety, right? What is the minimum standard you need to have to provide effective health outcomes and healthcare delivery and safety? But you're always trading off these things. The sustainability, safety issues that Bill pointed out was a perfect example of that. And so, I would argue that we need to think about safety not as an isolated thing to consider, but as an integral thing with a lot of, throughout the process and throughout every aspect of design.
Okay, did everybody hear that?
Is there a question?
Well, so the question is,
do you agree?
Do you agree?
To engage debate about that, right? The merits and limitations of that. But how do we reconcile that all these conflicting things? That's the question.
There's a tool that was used here. Bill actually showed an example of it with his relationship of the environmental conditions to safety conditions, and it's called quality functional deployment, and I call it a matrix, right? And what you're basically doing, this was originally invented by Ford to do a door, right? Because there's conflicting things all the time. If you're on a hill and you want the hinge to be tight so it doesn't rip the door open, right, or rip it shut on you, when you're on a level place, that may make it too hard to shut. Okay, so they're trying to figure out a method to deal with all that. And basically what you do is you put variables on one axis and usually the same variables on the other axis, right? And then you just kind of go in every cell and you make some judgment about the effect of that with each other. And the thing that I think everyone would find here is that if you front end the design process by doing a matrix around safety, quality, and all the other key building principles, because almost every organization you go into says they want it to be patient-centered and they want it to be safe, right? And they want it to be financially, and they want it to be lean, right? They want it to be environmentally sound. Well, all that has design feature implications, right? And if you put down all the cool ideas everyone could have, right, around those ideas, it would cost you 5 times how much capital you have, right? And some of them are going to be in conflict with each other, right? So the QFD model, I think, is an outstanding thing to front end a project with, because it allows you to get all those variables out there and have the organization debate them with the building team about what are the ones that you actually are going to use in the design process, right? So that you don't get to a classic where you enter the process and you get down to the equipment planning and you can't get the technology you need to make the thing really safe, right?
I mean, and that works great with 2 axes, right? But then there's a half a dozen other dimensions that have to be considered at the same time.
Sorry, go ahead. This is not going to answer your question. It's just going to make you more depressed. But it's a reflection of the world, and probably more specifically of medicine. And why do I have to go see a nutritionist and a radiologist, and et cetera, et cetera, et cetera? Because it's very damn complex. And so this is a question of how to solve complexity. I don't think it's specific to.
No, but I think just adding to what John said, the QFD does, it's not 2-dimensional, it is multivariates. You can factor in X number of your variables. The question is, the real interesting thing about it is, how do you weigh it?
Right.
And that's where it's a little bit of an art, a little bit of a science, and a little bit of voodoo magic, reality is, because that's as an organization, what is more important to you? And that's the dialogue at the leadership level. It comes in is, does safety, what aspects of branding, cost, environment, flexibility, et cetera, experience, because your marketing people are going to say, how are you going to brand this? Your nursing people are going to say, what about, your facilities people are saying, operationally, how are you going to, but it's the weightage which you can give to kind of, it's not a perfect science, but it's a tool which kind of helps you bring it a little more closer, to the answer than what we have today.
Yeah, you alluded to it, and John alluded to it, is the art of some of this stuff too.
It's judgment.
It's a judgment.
Because I can have a checklist on my flight, and then I can have a pilot that gives me a really rough landing and deceleration. You've all been on a plane when that's happened, right? Now that affects your experience of flying, right? And that pilot has also done the checklist. So there's an art and science to this, and I think for a long time we've downplayed the science part of it, and it's all been kind of like touchy-feely and intuitive, and we need to introduce the rigor into the process, but we can't lose the art of how you pull complex problems together and deal with those conflicting issues.
The value of doing the matrix front end is that it puts the variables, it puts the discussion before you design something. It puts it in front of you.
It's requirements definition.
Exactly.
So I think one of the things that Rob spoke about was the different types of research methodologies that are used. And we're talking about this matrix and checklist that, because it's such a complex problem, probably needs to be integrated with other tools as well. So Rob, can you tell us a little bit about some of your experience, especially with observational techniques? You had mentioned that what the clinicians said they did was different than what they actually did. What is some rigor around observation that could support this?
Tough question. Did I suggest that to you?
Yes, you did.
Well, a couple of things about that. One is a lot of research techniques are easy to apply but tough to master. So interviewing, surveys, observational research, superficially they seem very easy to do, but to do them well, and when I mean doing them well, there's the data collection part of it, but the real core part of it is actually turning into something actionable, having the judgment. I train people to do research, and you kind of get like these 3 categories of people. You get the people who, you probably have people like this in your 2nd grade or 3rd grade class. They write down everything the teacher says. So these people, they try to document everything because it's all important. They have no filter. And then you have other kinds of people who they have enough information or enough knowledge that they'll only note or notice something that's out of the ordinary, and so they'll kind of miss the basics because they already have a model of that. And so a lot of that skill is in developing that filter. Another just kind of perspective on it is applying techniques from other disciplines into your research. So one of the areas I'm particularly interested in is applying ergonomics to observational research. So when you think about ergonomics, there's a very hard quantitative science to it. And then you know, the everyday person, you might notice something, but you can actually put some structure around ergonomics. So when you're observing a patient or observing a nurse, you can actually, kind of like a checklist, you can categorize, is this a strength issue, a posture issue, a reach issue, a clearance issue? So rather than just having kind of these free-form notes and free-form observations, just putting some structure around them, I think goes a long way, without like a lot of technology or cost.
So Bill, you were going to say something as well. How do you supplement your flight-ready checklist?
I was actually going to say something different. This is the challenge of missing the conference call before the conference. But I was just going to that I've heard it said that 50% of what's taught in medical school is wrong, except we just don't know which 50% that is. And I think when you apply that to design, I think it's very difficult and not necessarily all that beneficial to try to standardize the design process. While I do think it's extremely valuable to standardize appropriately elements of the built environment. And I guess where it leaves me with is feeling that we're all in great need of understanding more about the intentional and unintentional consequences of all our design decisions, therefore the importance of evidence-based design. We need to understand more. At the same time, constantly apply the judgment that very little about what we're designing for is static, and it's constantly a running target. So I guess ultimately it gets down to not the, in my opinion, not the credible research itself, but our judgment of how we apply it, kind of like how translational research in healthcare takes bench research and in many different ways applies it to a particular clinical context. It doesn't do a whole lot of good if it stays in the laboratory. It's only good when it gets applied based on those multitude of variables that are different in almost every healthcare setting.
Ellen, you know, what I've heard all of you talk about is a wonderful process for really sifting through what all of the possibilities are, and then applying the judgment of your team in the context of the demographic that you serve. It seems to me that it's a process that goes back and begins to inform the strategic plan with which you started with. And what I've seen both in the facilities arena and the IT arena is there's almost a mini cycle of development. That if you do it well and you spend time at the front end and you use a variety of these tools to really focus the strategic mind on where you're going, that you'll be better served over the long term. In most projects, what I find is that absolutely does not happen. They're going to build a building, maybe it's market share, maybe they've got a rotten building, but they don't think about what the opportunity is to really transform the services inherent in that facility.
Exactly.
And I think each of the processes that you've laid out here is a way of sharpening the minds of the C-suite, the board of directors, representatives from the clinical community that you serve, so that at the end of the day, such as it has been here for Tejas and the Virtua team, everybody was on board through a variety of means that were used to truly identify what the focus was going to be for that building, and didn't really lose the message, kept reevaluating and taking their pulse, making sure they were still on track, measuring the variables continuously, and they did that because they engaged the whole team in the process. It wasn't just Tejas's process, it was a small group of individuals. So could you speak to how you've seen these processes help inform a strategic plan that really does realize improved outcomes at the end of the day?
I can think of maybe two examples, one general and one specific. And the general one is kind of what led us to the checklist to begin with. And those architects in the room, or those who are familiar with the design process, I'm sure you all have been in this situation where you've got a great visioning session, a great set of goals, and actually, not always, but hopefully frequently, have a real clear vision of what you want to accomplish. And then I think very much like multi-specialist healthcare providers who often have different agendas that don't always play as well as we'd like. You know, they're often competing with each other for patients as opposed to collaborating. I think the design process is very similar. or whether it's architects, engineers, owners, people who have financial agendas, people who have innovation agendas, people who have safety agendas, they all have a different priority or different value to each of them. And somehow in this process, those clear goals get watered down. So a generalist answer to your question is the tools that I think we can apply to keep us going back to those core values that we set in programming or visioning become really essential, because I believe without them, those great ideas almost always evaporate, either completely or partially. Specific example, I'll use a Pebble project, Peace Health, and the Lola Fritz study. When we were designing Peace Health, there was already a bariatric issue, and we knew, or the owner knew, that it was really necessary to install lifts in X% of the rooms. And there was a working assumption that the financial ROI was going to be 5 or 8 year payback, the cost of those lifts, which is significant, and the benefit would be at least a 5 to 8 year payback. And I was talking to someone here about when we did mock-ups for that project. They weren't just design mock-ups. They had the luxury of this building 4 rooms in the existing hospital based on the new proposed design, and using them, having patients in them for 6 or so months. And the ability to take that mock-up to the next level of actually experiencing it clinically led to huge design changes that were done at the right time because they were early enough, but in particular, what was tracked was not just the cost of the lifts, but the direct and indirect savings, financial savings. So there was a financial pro forma, which too often isn't done, that to sort of get to the bottom line of this story, with all of the benefits, not even including potential litigation costs, the financial return on investment for those lifts was much, much shorter than anyone believed, and it led to, this is the important part, an informed decision, because there was quantitative and qualitative. Someone showed the quantitative, qualitative, generative, and I forget what the other term was, matrix. Informed decision-making that could, again, talk about those multiple variables: safety, patient outcomes, financial return, construction details. To make an informed decision was a no-brainer, and lifts were put in all of the rooms, and it was a very confident decision. So that's a specific example of that.
So, Jonas, I'd like to ask you, because some of the work that you've done has translated into the next project and the next project. So to Eileen's question, how does that inform the strategic vision? Can you tell us a little bit about how that information is communicated and then how it translates into setting visions for future projects?
Yeah, so I guess before we get to the future projects, but even with current projects, we start, like you're talking about, with the vision and values, and we kind of boil those down into research questions ultimately. So if the importance is access or integration of different team members, we'll talk to, for example, the anesthesia group and say, well, if it's important to access, give me examples of what challenges you currently experience. And so in our case, one of the anesthesiologists said, well, I can't leave the case. I'm kind of trapped in the corner of my OR room, and when we design this new hybrid OR, I want to be able to at least leave and get things if I need to, or send somebody. And so then that turns into embedding that into the scenario that we're testing it. And so then they actually have to perform that task that they identified as a challenge. In terms of how that leads to future projects, I guess, one of the things I guess that the architects have been finding quite useful is sort of like your checklist, but a little bit different. What they'll do is take our list of recommendations and go through the user team as sort of a sign-off process. And they say, so here's all the things that were identified through our simulation scenarios. The user team goes through it, and that's kind of where they get to the sign-off. And I'm not sure how I guess it translates into future projects, but currently I guess it's not embedded into Alberta Health Services. It's not mandated that they do this human factors testing, but it's been word of mouth and it's been successful. So there's design teams that kind of spread it around, and it's just been growing.
So that, I know there's another question I'll get to in just a second.
Can I just jump in?
Yes.
And I wanted to add something to what you asked. In the strategic planning or the vision setting, when the board goes out, one thing which was very beneficial for us is when Rich got up in front of the board, this is probably 8 or 9 years ago, recognizing there are two factors which lead to good results: the environment and the process or care delivery model. And really creating that burning platform to use facilities as a catalyst to transform care by the bedside. We all know, it's not the lack of attempt or lack of money in the US healthcare system. It is no rocket science to that. There are a lot of other environments outside the country and systems which have better outcomes. So the question is, at the leadership level, to kind of empower, use this as an opportunity to transform care. That's what got rallied down to the staff level. That created an impetus for us to kind of saying, we're going to change the processes of how we deliver care and use the environment around it to provide that outstanding experience. Because, and I think one of the things is probably the broadening of what evidence-based medicine is. Because we have a lot of focus on the environment, but sometimes, environment is only as good as people who make it work. And so how do you inform the environment design around what processes which are going to run on a day-to-day basis when the architects are gone, the planners are moved away, and the building is handed over? Can this building sustain? And it will be a challenge for us also, is a year from now, will this building function the way it was intended to? And will it kind of operationalize, because all these visioning sessions, planning, are only as good as once the key is handed over and how this facility will run. And because what happens is, there are so many facilities, because leadership changes between your planning and operationalization. We've seen that changes, surprise, surprise. But people will come and go. But what happens is your legacy processes, they always stay. And that's the opportunity in terms of facility design, which I think we need to recognize is, it's not only new building, new aesthetics, new decor. It's also the opportunity to transform care, and how do you get that burning platform going on in that organization?
We talk about processes, but I would argue here, you can feel it here, that the facility design, by changing the processes and by focusing on a new way of delivering care, is fundamentally changing culture here. And John Olson said it very well earlier when I was talking to him, is that by getting all the people involved with trying to figure out, like in St. Joe's case here, we organized around the adverse events. So everyone had to know what the adverse events was, how much it really does happen, what are the options to change it, what are the process changes we had to make to do it, right? And what happened was, when it was all said and done, it was the culture that was driving the adherence to stuff. And I was an example of somebody who left that organization, and we lost a lot of department heads when I left. And you can feel that it's not, when I've been back there, when you lose consistent leadership until that culture is really embedded, it's a problem, right? But the facility development to change culture and processes is to me the most important thing about getting an organization to really perform.
So, in that, we have a question.
I think these are some great ideas. That's speaking as an owner, someone who wants to see some of these things implemented. Who's going to do it? Because not all, I'm in a 1,200 bed organization. So multiple campuses spread across central Massachusetts. We've got management services teams. But what if I'm one of these 125 bed organizations that's going to do a renovation or is building a strategic plan? They don't have those staff. Who's going to do the QFDs? Who's going to do the matrices? Who's going to do the FMEAs? The architects?
Well, I think the organization has to do it with the architects.
It's your culture.
So what's directing us to do that? The guidelines? That's not going to happen.
No, you have to, we as a group have to say, we want this to happen in the field, you know, is what has to happen. I hate to say that.
And that's just gonna make it happen?
Let me take a step back.
I'm just asking.
No, that's a good question.
Are you asking, how are you gonna know that that's even an opportunity, or who, if you know it's an opportunity, who's gonna execute it?
Who's going to actually bring the thought process
Right.
first to the design team and the owner's design team? Who's gonna say, you know, we've done our last, Bill and I were talking about this earlier, we've done our last 4 or 5 projects, we've used this process. We think it'd be beneficial to do it here. Okay, that's one approach, and that's coming from the architect. But I don't think organically, systems, healthcare organizations, now you had here, I'm sure I had an enlightened CEO. Not all organizations are that have that benefit. So how does this roll out? How does this get, and I don't think I'm one of these guys who says the guidelines is not an operational manual.
Right.
It's a design manual. It's a minimum standards. So this could be appendix, best practice, something that goes in the back. We think you ought to use some tools like, but not specific tools. You don't have to use these things.
So
But some of these other pieces need to.
what's your recommendation? If you think it makes sense to do this, what would be your recommendation about how we could disseminate?
I would think that, that architects, design firms would use this as a marketing piece. Here's an asset that we can provide to you. Here's how we can tie into your strategic planning. Because that's also something that healthcare is not very good at, is strategic planning. We're very good at tactical planning. You know, but very few organizations take a very strategic, long-range approach. I'll call it a strategy, but it's really more tactical instead. So I think there are other methods, whether it's the white papers, whether it's through the AHA leadership, ACHE, there are different ways of getting information out there as well.
So I think I'll just add, one of the beauties of the group that we have assembled here is that there's so many different points of view, and that's really what we're hoping you have a chance to struggle with each other tomorrow, to try and get an understanding from different perspectives, what's realistic. And some of the tools that we've included are things that are already done within organizations. Do those become the most viable option, or are they not enough to support it? So you're gonna have fun tomorrow. I think so.
If I could just add a couple thoughts to that. I think there is a lot of diversity in terms of organizational models and the providers, and I think it's pretty clear that right now is not a time for small change; it's a time for big change. And I suspect those organizations like Kaiser's, the Cleveland Clinic, the VA, where in one way or another the physicians are employees, if you will. Although they're massive organizations and it's a lot harder to move a battleship than a speedboat, probably those organizations that have some kind of a governance structure in which there are sort of employees, it's not the right term, but everyone sort of is working for the same entity, will probably find it a little bit easier to make massive change than the majority of the organizations where there's all kind of long history of physician owner negotiations and different agendas. And I think I raise this point because I think it's important to recognize that there probably are different strategies for the different organizational models.
Can I just add one quick thing to this? And it really has to do with the Affordable Care Act being implemented and the profound opportunity that it brings with it. In the past, hospitals got paid for the harm that they caused. There was no denigration of the dollars that they received. And in 2008, that began to change with the NEVER events, the serious reportable events. And now that's been taken one step further in the Accountable Care Act. And so hospitals now will not get their full reimbursement of Medicare dollars as they would have automatically unless they can demonstrate a reduction in harm. That has never existed in that way before. So there is an incentive in the C-suite to get this right. Not only to get the reduction of harm right, to get the readmission rates down, to get patient satisfaction up, and to engage consumers in ways that we've never done before. So I think that this community is very well positioned to articulate the role that the physical environment plays as a tool to eliminate some of the latent conditions that contribute to this harm and ultimately are going to reduce their margins. That's the piece that I think we need to be
I
able to
think
share
you're
with
exactly
them.
right. I think it's really almost a means for survival more than an incentive.
I think you're also gonna see, hospitals hold their vendors or the architects somewhat accountable in producing, safe buildings that lend the results that they want results. So I'm telling you, I've heard a lot of talk about that, is how do you make your vendors have skin in the game?
Yes.
Yes, okay. So put your visioning hats on for a minute, and let's go move far into the future with these kinds of thoughts. And think about the airline industry is always used as an example of an industry that drastically reduced incidences that are coming. One of the ways they did this was to standardize their control panels in there. So we know that there are better ways and best ways to design patient room and possibly a toilet room, although the jury's still out on that, how to put those three fixtures in the proper relationship to each other. But let's just suppose for a minute that all this research is funneled into designing the perfect patient toilet room, as perfect as you can make architecture to support patient safety. And let's suppose that you hook that toilet room in a configuration that has been judged by an evidence-based design that is the best and perfect model. And then you go to the patient room, and that patient room has now been designed to where you cannot change anymore, because what we're doing here, we're always reinventing the wheel with every group that's going to build a new hospital, as if this was the first time a hospital had ever been built. And so everybody goes through this whole processing again, and they're coming out with different answers. But let's just say that all this research in 50 years has resulted in the perfect design. Can we then get rid of all the architects?
Actually, it just allows them to be more innovative and creative. I was thinking as you were saying that, there's another healthcare institution in New Jersey where the CEO was very frustrated by what you've just said. How many head walls has my architecture team designed? Why do we need to go through this over and over and over again? Just imagine the luxury of time you would have if that was done and you could actually put your creative juices to solving some of these other safety issues.
Yeah, play with the exterior of the building. Leave my patient room and toilet room alone for crying out loud. This is the best as it gets.
They're
Standardize it across the nation and
yeah.
across the world.
The National Learning Lab group and had this concept of mock-ups day one, right? And when we sat down with the architects and we said, what does that mean? I thought you did mock-ups way down in the design development stage of the thing. And what we came to understand is exactly your point, Skip, right? Every architect that shows up that's worth their salt, right, already has half thought what this room is gonna look like, right? So why don't they put it out there and say, this is our first crack at what your patient room should look like, right? We've done tons of these in the past. This is our first crack. Now you start testing it against your processes, right? It makes a lot of sense, because if you sit there and say, well, you can have a patient room look anywhere, well, it's not, in a way, right? As architects, you folks have sat there and thought, well, I don't know if that's such a great idea. I'll convince them in a while that that's not a great idea. Isn't that true?
Oh, yeah. Well, the research is not done yet. We don't have a perfect patient room. We don't have a perfect patient toilet room.
But you have one in your head.
I can't get one put together and say, this is it, buddy.
See, as my son so often tells me, I'd like to agree with you, but then we'd both be wrong. I don't think there is, nor should be, such thing as the perfect patient room, not because I want to stay employed, which I do, but I think Bertrand Goldberg came up with what he thought was the perfect nursing unit, in the 60s. It looks just like Marina Towers, except it's in a parking lot instead of on the Chicago River. And they were all over the country, and they probably did work really well in some ways for 1960s nursing care. And it is probably the most difficult, unchangeable model of care if anyone's got one on their campus, you know what I'm talking about. And again, I go back to the point that there's very little about anything about the environment that we're designing that is remotely static. As we were walking through this beautiful facility a couple hours ago, I had a conversation with Dave Allison about and with John about, you know, this notion of always having the toilet room on the head wall side of the patient. And it's almost ingrained in healthcare architecture 101 that that's the way to do it. And we began this conversation about the patient rarely gets up where the pillow is on the bed. It's almost always at least in the midpoint, and there's all kinds of equipment. And so I'm even now going back to the sort of the root cause of the recommendation of toilet room on the head wall and say it's flawed. I'm still not sure it's the wrong thing to do, but I think it's for different reasons. And without being sort of too philosophical about this, I'm having a real hard time as a healthcare architect who's been in this business for close to 30 years to even understand well enough the most basic, it's kind of sad and embarrassing to admit it, but some of what really, really, really are the most basic drivers of all the things that we think are givens. And I mean, I would ask the same question, what is the best automobile design? And why isn't every car like it? And why don't we all go buy that car? I don't want to be in a world, either a patient or a designer, in the world where there is the right answer.
Well, actually on the car design, through the crash test, they did come up with the best design for automobiles. All you're buying is the skin on the outside and the size of engine that you want to drive it. You're basically all sitting, we're all sitting in basically the same.
But I say they're all very different.
The basic designs are the same, but if there is a design that is best to promote safe practice, then why don't we find it?
Well,
It can't be that tough.
I mean, we have,
the delivery of care is all the same.
Skip, in order to keep us on track here, I would suggest that we're going to have this great networking party following the day. Then have a drink, and this conversation is just going to become the most fascinating thing that we're going to go through.
I think we should fight. I think it should be fist fights.
As one guy that I used to work with said, cage match, yeah.
one more comment. As someone with the lineage of the guidelines, historically, right, it was the cookbook. Remember the cookbook?
Yeah.
They thought they had that.
Yeah.
There were hundreds of Hilberton hospitals built around this country. They thought they had a great design, and now they're totally functionally, inadequate, right? And the problem is this building. The question isn't how this building's going to perform according to the operational objectives next year. It's how it's going to perform 25 years from now, when we can't even imagine the changes in healthcare, right? So we look back 25 years, and we look forward 25 years. There's going to be twice the amount of change there was looking back 25 years. We can't even imagine the patients, how care is going to be delivered. So I don't think there is a perfect room. Perfection assumes stasis, and we're in a very dynamic environment. So the issue is, how do you design for safety, but still maintain that loose fit, long life kind of probability as conditions are constantly changing?
Okay, and with that, I'm going to turn it back over to Angeli so that we can wrap up for the day. But I'd like to thank all of our panelists and the fact that they stuck to their 10 minutes.
I'm going to introduce John Grout. He is the Dean of the Campbell School of Business at Berry College. He's an educator who serves as the Dean. He received a BS from Brigham Young University's Marriott School of Management and a Ph.D. from the Penn State University. Some of his most notable research focuses on the Japanese term pokoyoke or mistake proofing. He received the Shingo Prize for Manufacturing Excellence in Research in connection with research in his field. So I'd like to welcome John Grout.
Well, before I get started on my prepared presentation, I thought I'd like to just make a few comments based on what I've been hearing. I continue to see James Reason referred to, and I continue to see the Swiss cheese model. And one of the things I notice about that is that we never talk about how many slices of cheese are in the model. And I question that because from my perspective, as I look at different industries, I find that healthcare is not well defended. You walk into an airplane cockpit or a nuclear power plant control room, they understand about the Swiss cheese model. They understand there's going to be holes, but they also have lots and lots of slices of Swiss cheese to cut down on the number of holes. Healthcare's never done that. Second item, let's do a functionality check. Would you please raise your hand? Doesn't matter, just one. Thank you. Okay, so we got the functionality check. How many of you are familiar with QFD? Okay, for the rest of you, the reading assignment for today, see, I'm a college professor, I can do this, is to read The House of Quality in Harvard Business Review, 1988. That makes it ancient history. By Hauser and Clausen. And that's kind of where it all kind of got started. And so that's a good starting place on that. It is a translation mechanism in matrix form to go from what you want to accomplish to how you're going to accomplish it. And it's in that it has power. The other thing I heard was that there was a conversation about how you weight different factors. If you're interested in just completely getting outside the box on trying to weight different aspects, you should read Choosing by Advantages by Jim Sir. That's S-U-H-R. It's Choosing by Advantages by Jim Sir. And Sir is spelled S-U-H-R. Lastly, I hear a lot of talk about kind of quality and about the design process. And one of the things I don't hear a lot of talk about is Jim Reason's breaking errors into, or actions actually, into skill-based, rule-based, and knowledge-based. We talk a lot about quality, and we like to talk about quality in terms of reducing variation. It turns out that in design and in a lot of other areas, reducing variation is not what we want to do. What we want to do is maximize variation. In particular, if you're working in skill or rule-based actions, you want to minimize variation. If you're working in knowledge-based, you want to maximize variation. And so when we're designing things, we don't know what the right answer is up front, and that's where we want to maximize variation. So those are just some kind of thoughts I had on the top of my head. Thanks for listening. We also heard about never events. And so I want to talk a little bit about a never event. And in particular, my never event has to do with my table saw at home. My never event is I don't want to cut off my finger. My father actually lost his finger, his right index finger, to a table saw. I don't know if you all can, if once the talk is done, we get to the reception. If anyone can think of an industry, other than what I'm about to mention, please let me know. But there is one industry where they will sell about $900 million worth of product a year. And the medical cost of treating people who use that product is about $2 billion a year. So this is an industry that is creating medical costs at double the rate of their entire market size. Now, can you think of any industry that would meet that? I'm thinking, skiing might be close. I'm thinking trampolines maybe, but that data is about table saws. It's about table saws. And so before I get into my prepared remarks, what I want to show you is what you can do if you think about it from a design perspective, and to hold up kind of a banner of hope to the idea that we can dramatically change outcomes through design. And so I'm going to play a little clip because it'll liven things up a little here. Okay, everybody ready?
Time warp. Here is a good rule of thumb, or potential lack thereof. Table saws can bite. A quick demonstration. Wood. T-bone steak. Wood. Steak. Wood. Steak. Are we clear on this? Good.
Yeah, there's about 60,000 medically treated accidents on table saws every year. About 3,000 people take their fingers off, about 10 a day. Oh, 10 a day?
Steve Jonas, a lifelong woodworker, is trying to bring that number 10 down to 0. He has developed a system that stops the blade of a saw if it comes in contact with your finger. He calls it Saw Stop.
The system can tell the difference between your finger and the wood. So when you're cutting wood, if you accidentally run your hand into the blade, it'll stop it so quickly that you just get a little nick instead of maybe taking some fingers off.
The blade is a sensor that detects electrical conductivity. A piece of wood is not very conductive, so the saw goes right through it. A salty, wet finger is conductive.
Well, it's a lot like a touch lamp. There's a small electrical signal on there, conducts that signal into my body absorbs some of the signal. That triggers the system. It'll detect that in less than a thousandth of a second.
Okay. Any volunteers? Yes. We're going to use a salty, wet, conductive corned beef flank.
So I'll hold it just like it was my thumb.
You gotta be kidding me. Let's see. There's nothing. That is amazing. That really, I mean, that's it's like nothing ever happened.
The blade is rotating at about 5,000 RPM. It's forced to stop in 1/1000th of a second. It saves a finger, but mangles the machine.
You have so much momentum in here. You're decelerating something at like 1,000 Gs, 1,000 times the acceleration of gravity.
Now we get worked. Machine stops on a dime, or in this case, a franc. Machine is not happy about this fact.
Any way that this asymmetrically hits the weight is just going to put huge torques. You're slowing this thing down at 1,000 Gs. We just have no human reference to what that means. That's like driving a car 1,000 miles an hour and hitting a wall.
Yeah, concrete wall.
And it's just flapping like it's a piece of paper.
5,000 RPMs is a lot of energy. The energy has to go somewhere when it stops, so it's transferred to the saw stop module, which acts like the crumple zone in a car. The module and saw blade are now officially trashed. But hey, at a cost of about $60, better to pay that than with a finger.
It's an amazing idea, and it's implemented in a way where you're using energy for its own stop.
Steve Gass is a true believer in his design, which brings us to our next demonstration. Steve is going to put his own finger into the table saw.
How are you feeling about this?
I'm a little nervous.
Yes, you knew we had to go for it.
I don't much like doing it, but it is such a unique opportunity. Let's do it.
There's not going to be a take two here. Having everything set right is crucial. As if you need a reminder, this is with saw stop. This is without. Without. That mask Steve is about to put on isn't a protection from spurting blood. It's to protect his eyes from the bright lights needed by our high-speed cameras.
Yeah. Now you want to try putting your finger in there and just...
But you are never going to try this at home, right? Right? Lights, camera, conductivity.
You all right?
Yep.
There's no blood. There's nothing.
No, didn't hurt.
His fridge. Now we bet you've never seen this before. A finger being shoved through a table saw. At least, we hope you aren't one of those unlucky 10. We know the machine stopped, and we know nobody got hurt. But we gotta say it. Ouch!
It felt a little like a, I don't know, a buzz or a tickle almost.
You're talking about your finger in a table saw, and you're talking about a buzz and a tickle.
We've done a lot of bizarre things in our lab, but somehow this demonstration of a man's faith in technology is one of the coolest.
That was an unbelievable thing to do, and you've proven your point.
Wow.
So the question is, why does the skill saw adopt that?
Oh, I have a long backstory on that. Steve Gass, by profession, is a patent lawyer. So the first thing he did, of course, was patent it. Then he went around to every table saw manufacturer in the entire world and pitched it. None bought it. In fact, they would have meetings like this with their lawyers to talk about how they had to not break ranks. Because as soon as one person did it, everybody would have to do it. So he decided to find a contract manufacturer, manufacture the saw. It's now the top-selling saw in the table saw market.
Wow.
And no one else, they continue to say, this is unproven technology, and come up with as many reasons for not doing it as they can. In the meantime, the other place that you might want to check on the web is www.tablesawlawyer.com. Because now that this technology exists, if you don't implement it, you're negligent.
Yeah, wow.
So there's a two-edged sword to this. I mean, there's troubling aspects to that, from my perspective.
Is that happening in healthcare like that?
I anticipate it could well do that. So I think we all have to be very careful about how we approach that and think that through. But I think it's a very useful case study in terms of what can be done in a profoundly dangerous industry using design as the tool. And so it's in that light that I want to talk about mistake proofing. And I just thought that would kind of get your juices flowing as far as what mistake proofing might be all about. So I'm going to talk about mistake proofing. I'm also going to talk about lean. How many of you are very clear about lean? I got more people for QFD. That's crazy. Okay, and then I want to talk about flexibility, because I think one of the last points that was made is we're going to have to build hospitals for 25 years from now. And every cutting edge organization I've ever seen fails to be static. They all are improving. So if you take the ones that have done lean and are doing just amazing things with lean, you say, well, okay, so you've arrived. And they say, no, we're just getting started. Because once you see how it works and you get into one of these improvement cycles, you want to do it again and again and again. And so you will constantly be changing that standard work. And so we want everything to be standardized because we know that that's going to help reduce errors and improve quality and improve efficiency. And we're also wanting things to change. And that's the tension between how do you freeze it and when do you thaw it and how do you make these improvements. So those are kind of the three themes I'm going to be talking about today. Mistake proofing is the use of process or design features to prevent simple errors and their negative impact. Okay? Generally speaking, mistake proofing will not work on knowledge-based errors. That is, errors where deliberation is required, where you have to think about what the right answer is before you can do it. It works reasonably well on rule-based. It works very well on skill-based. Rule-based is where you think up a rule or you recall a rule and apply it. So like when you're driving up to a stoplight and it's blinking red, it doesn't happen all the time, but when it does happen, you know what to do because you've got a rule. Okay, that's rule-based. Skill-based is the things that you do almost on autopilot, that you don't have to think about very much at all. And so mistake proofing is going to work well in skill-based, not so well in knowledge-based, and rule-based. It'll depend on circumstances. It's also known as pokey, pardon me?
Give an example of the second one.
Of
Skill.
Of skill-based.
Skill-based action are just autopilot things. Have you ever driven through a stoplight and then looked in your rearview mirror to see if it was green? Okay, I've done it. You know, I drove through, and had it been red, I would have stopped. But I do it so automatically, I don't even remember looking at the light. Okay, so skill-based is everything that you do on autopilot. And what you will find is that where you do repetitive work, a lot of that work gets done on autopilot. Have you ever, I guess for the medical personnel in the room, have you ever, thought of an error that was made in your facility and said, if they'd just pay attention, we wouldn't have this problem? That's usually a skill-based error. Mistake proofing, also known as pokey-okey, tends to be inexpensive. It also tends to be very expensive. Effective, not expensive. Inexpensive. Yeah. It's already in healthcare. And the reason I know that is because I wrote this book, Mistake Proofing the Design of Healthcare Processes, which you can download off the web for free or just call them on the phone, AHRQ's Publication Clearinghouse. They'll send you a copy for free. It has 150 examples, and it has kind of a whole theory and process of how to do this stuff. It is not a standalone technique that will eliminate the need for other responses. It is just one tool in the toolbox and needs to be used where it's appropriate and not used where it's not appropriate. It is also not a solution for complex system failures resulting from unanticipated interactions among tightly linked systems, AKA normal accidents. It's widely known and practiced in manufacturing, not widely known or used in manufacturing, although that's changing in the last 10 years or so. But it's even less widely used in services and in healthcare, and it is not the recommendation of just one discipline. I tend to come out of a business background, and so from a managerial perspective, it makes sense, but there's a whole lot of other ways it makes sense. So many in healthcare kind of read the works of Reason and also of Donald Norman. And Norman recommends using forcing functions. Many of you may have heard the term forcing function. I think that that's a synonym with some of the mistake proofing devices. Not all, I think it's a little narrower. He says, actions are constrained so that failure at one stage prevents the next stage from happening. They rely upon properties of the physical world for their operation. No special training is necessary, and he differentiates between knowledge in the head and knowledge in the world. And he recommends knowledge in the world. That is putting artifacts into the process by the act of design that keep things from going wrong. Henry Petrosky, a mechanical engineer, says, we rely on failures of all kinds being designed into many of the products we use every day, and we've come to depend upon things failing at the right time to protect our health and safety. We often thus encourage one mode of failure to obviate a less desirable mode. Okay? When the saw stops, it destroys the machine and brings it to a halt in microseconds. Okay? That's a failure. Normally, I don't want that to happen to my table saw. In this case, it does. And it keeps the next step, which is me cutting my finger off, from happening. In medicine, Croteau and Shivey say, a process that is designed to detect failure and to interrupt the process flow is preferable to a process that continues on in spite of the failure. We should favor a process that can, by design, respond automatically to a failure by reverting to a predetermined, usually safe mode. And notice here that the key word he's saying is it ought to interrupt the process. An interruption is a failure. And in quality management, Shigeo Shingo was the coiner of the term poka-yoke. If you tell that to your Japanese friends, they won't understand it because it's slang and it tends to be in the automotive industry. But he says that when abnormalities occur, shut down the machine or lock clamps to halt operation, thereby preventing the occurrence of serial defects. With the idea of discovering errors in conditions that give rise to defects and perform feedback and action at the error stage so as to keep those errors from turning into defects. Okay, so we've now seen it from kind of 4 different lenses. The recommendation is essentially the same. We need to bring people to a stop. We need to create barriers. So let's talk about some examples. Up at the top, we have a film bin. I suppose this is probably starting to become obsolete, but it's in a dark room. You can't open the door unless the lights are out because it has a light sensor on it. Very simple technology. Down below, my local hospital has a door to the X-ray room where if the door is open, the machine will not operate.
I just wanted to comment on the second one. There's a lot of debate that device will terminate an exposure so no one gets radiated. The result is the patient actually ends up getting additional exposure, and there's a debate about where the real benefit is.
Yeah, and I think that there's always, you ask your doctors, which medications don't have side effects? There's always going to be secondary problems with every mistake-proofing device you do. If we hold mistake-proofing devices to the same, if we say we are unwilling to accept secondary problems, that means we should get rid of any medicine with a side effect. I don't think that we should hold these interventions to a higher standard than what we hold to the things we put in our mouth. In the meantime, I think that there are a lot of type A, B, and C issues. You know, does it stop the wrong behavior that we want to stop? Does it stop right behavior? Or does it cause some other kind of right behavior to be excluded too? So that's why I'm talking to design people, is because there's lots of issues and simplicity is not simple. And in this case, yeah, I think that you clearly want to have a situation where perhaps this is a little more sophisticated than just an on-off switch at the power level. You know, maybe this is, you can't initiate an exposure or something like that. But you're always going to have those issues. And you have to work through those and think through what is the safest thing that you can do. You end up in the basement where you don't really want to be when there's a fire drill. Of course, the solution is to put a gate there. That's a very simple mistake-proofing device. You'll find that a lot of mistake-proofing is not rocket science. Helping people to have visibility into the process is a very weak, but sometimes very effective form of mistake-proofing. In this case, you can see for each patient who has a number there where they are in the process. We saw a similar example here in the building today. This is communicating with a linoleum. So we have an individual at Centara who is inside the box here. This is the no interruption zone. And so while you're pulling meds and you're inside that box, no one is allowed to talk to you. So it's a form of sequestration to make sure they can keep their mind on their business. Over here we have the 5 Gauss line so that you know if you're getting close to the magnet or not. This is in a hospital simply to indicate you should be wearing your scrubs past that point. And so as they walk over those tiles that are in a pattern and colorful, it just reminds them that they need to have their scrubs Does this one look familiar, John? This is if you're into Japanese words for everything, this is a Kanban. This is a system for signaling when you need to check that a room needs to be restocked. So as soon as you open a drawer, it tears the label and it tells you that, it tells the material handling people to check it and refill it on a daily basis. That way you don't run out. Very simple mistake proofing, no rocket science. These are head walls from 4 different rooms in 4 different areas of St. Joe's as well. What you will notice is that they are identical. Some of them have a different number of outlets, but everything's in the same place. So no matter what room you walk into, that standardization helps you get things right. Wayfinding is an issue in hospitals. Sometimes there's tape on the ground. This is New York Presbyterian that has the sneakers to help you find your way around the building. So lots of just very simple little design changes. Now, some caveats. I really like the gas outlets that have the pin indexing system. They all have a pin at 12 o'clock and then they have different pins across the way. You have to be careful. Here's another situation where you have to watch out for the secondary problem. The secondary problem is that if you have a regulator with one of the pins broken off, you end up killing 2 people consecutively in the same room, which is exactly what happened in one case. And the problem is that people will use mistake proofing to facilitate other behaviors. In this case, they were in a hurry, they didn't check, there was some draping in front of it, and they reached in, it fit, so it was good. And so it doesn't obviate the need for safety culture, it doesn't change, you have to watch out for that. As it turns out, anti-lock brakes are not all that great of a thing either. Why? Because now that we've got them, we drive differently. And so there's been no real change in the fatality rate or in the number of accidents because of anti-lock brakes. They were supposed to be a safety feature. We've converted them into a feature that facilitate tailgating in the rain. Okay? So we have to be careful about that. Now, how many of you are familiar with FMEA? Oh, see, that's a good number there. What I'm going to suggest is that with FMEA, we have a tool to understand failure. And what I'd like to propose is that based on those quotes that I read earlier, we ought to use them for two purposes instead of one. The first purpose is to determine causes of undesirable failures and implement preventative measures. That's the traditional approach. What I'd like to propose, though, is that we also ought to use it to determine ways of creating benign failures and use them as the preventative measure. Okay, you're in the hotel elevator. How many of you would consider being stuck between floors as a failure? Anybody consider that a failure? Okay, thank you very much. How many of you would think of having the elevator rope break and fall to your death to be a failure? Okay, that's a failure too, right? It turns out Elisha Otis created a failure for elevators, which is if the rope breaks, it gets stuck between floors. That mistake-proofing device facilitated high-rise buildings. Before that, you didn't build higher than about 5 stories because no one wanted to walk. And they didn't take elevators for risk of falling to their death. Now that there's a solution that came in 1853, more or less, we have a fix. And so we're going to create failures to stop failures. So the curious thing about mistake proofing is what it suggests is that if you have a failure you really want to avoid, the question you should ask is, what any other one failure would I prefer? And so I've used a fault tree here. If you are into root cause analysis, you'll recognize that event trees look a lot like this. And so we have a harmful event, and we have all these causes. This and this could cause that, or this could cause that, or that could cause that. Over here we have a more benign event. Okay, so this is being stuck between floors. Doesn't happen very often because we have cause A and cause B and cause C all required in parallel in order to create that failure. Here's what I'm proposing. Why don't we take something off of this tree and move it into that tree? So that now, when the rope breaks, instead of falling to our death, we get stuck between floors. And the nice thing with this model is we still know that we've got a whole bunch of other issues to look at. Okay, so a woman is scalded with third-degree burns over 80% of her body, and she passes away. This is since some of you may not be familiar with scalding, the issue is that normal water temperatures are set, or water heaters are set between 140 and 160 degrees. And here's the number of seconds in order to get a third-degree burn from water. And what you can see is that it takes a minute and a half at 125-degree water. When you get into the normal range, it's 5 seconds or less. Okay, so rather than being scalded, what any other one failure would you prefer? You'd prefer cold water. Okay. Or maybe no water. You know, you wake up some morning and your pipes are frozen and there's no water coming out. That's a significant failure and it will wreck your day. But as opposed to getting burned, it's very attractive. And it turns out that in this case, people have thought about this and there are off-the-shelf solutions. There are thermostatic mixing valves. Here's another example here. There's also add-on devices where you can actually just screw it into the shower head or the sink. And I don't think I have a video there. But essentially it's, you know, when the water gets to a certain temperature, it just turns off. Actually, it just starts to dribble at that point. It has to dribble so that when you turn the cold water on, it can get in there and open things back up. But the moral of the story is we want to think about how to make things fail. Let's see, how am I doing on time here? Oh, I'm doing okay. So, Dick Chase and Doug Stewart did some work on mistake proofing, and they wanted to apply it to services generally. And since healthcare is a service, I think it's important to talk about this aspect. What they said was, you know, you have to think about the provider and the patient. It's not enough just to keep medical personnel from making mistakes. You also have to keep the family from making mistakes. You have to keep the patient from making mistakes. And so they divided it into provider countermeasures and patient countermeasures. And so we'll go through those. So on the provider side, you have the task, which would be doing the work incorrectly or not requested or wrong order or too slowly. Interaction countermeasures, excuse me, which is lack of courtesy or professional behavior, and tangible countermeasures like errors in the physical elements of the delivery system, like a wrong medication. And there are all kinds of examples of that from other areas of service industries. So, you know, cash registers that have the button labeled with the item instead of just numbers. You know, you see that at McDonald's. I'm not sure if that's a good thing or not. Tags to indicate order of arrival. I think we saw a joke about that earlier in the session. Interaction countermeasures, you know, a bell on the shop door, so when you walk in, they say, oh, someone's here, and they come serve you. The most interesting one I've heard in a while is that there was a bank that wanted to have more personal service. And they were concerned that the tellers would sit there and do their work and not look up. And so they added a field to the transaction, which was customer eye color. So that you had to look up, look at the eye color, record it as part of the process, so that you would get looked in the eye at least once. Now, I always get the question, so let me save you the problem of asking it. Why don't they just put in blue every time? And I don't know the answer. I would hypothesize that you could put that in the database early and you would have to match whatever it actually was. But, and tangible ones, I think everyone gets a handle on those. On the patient or the customer side, other services have customers. So you have preparation countermeasures, the failure to bring the necessary materials to understand their role or to engage the right service. One of the problems is having people bring their medicines or to do any pre-medication that they have to do. Finding ways to create mistake proofing for that would be very effective. You have countermeasures, which are inattention or misunderstanding or memory lapses. You always get the little piece of paper that tells you what to do with your medications because they know you may not be thinking about it. At the moment, they're giving a long explanation about it. And then resolution countermeasures, which is a failure to signal service failures or provide feedback or to learn what's expected. And there's some examples of that. The height bar in the amusement park to make sure that you have to be this tall to ride on the ride. So those are some general ideas on both the provider and the patient mistake proofing. Okay, let's talk about lean for a minute. And since lean wasn't nearly as good as failure mode effect analysis in terms of how many people said that they got it, I'll go through this. We want to talk about something called the value stream. The value stream is the set of all of the specific actions required to bring a specific product through the 3 critical management tasks of any business, which is problem solving, concept design, launch, information management, order taking, scheduling, delivery, and the physical transformation of raw material to finished goods. And so whichever of those is most appropriate to you, you want to figure out what that value stream is, and then you want to get rid of wastes. And here are the 7 famous wastes, which those of you who know lean will be very familiar with this. Overproduction, waiting, transporting, inappropriate processing, unnecessary inventory, excessive motion, and defects. And so anywhere we see those in an organization, we ought to get rid of them if we possibly can. On transporting, Park Nicollet Hospital has a cancer facility where everything comes to the patient. And they're quite proud of it. It works very nicely. And that was part of their lean efforts. Overtreating is a book by Shannon Brownlee. She points out that if you have an MRI machine, that MRI machine will work at roughly capacity. If you have 5 MRI machines, 5 MRI machines will run roughly at capacity. And she questions whether medical necessity is really driving all of the tests that go on. I don't want to go into that necessarily, but there is evidence of some inappropriate processing as part of the medical system in the United States. Okay? The next thing, after you've got a value stream, you want to think about what value means. And so when you go for a trip, how much of what you experience in the airport is really value? For example, is driving to the airport value? Possibly. Having to park and get on a van and go from the van to the airport, is that value? I think it's starting to be questionable at that point. When I'm in Salt Lake City and I want to fly to Atlanta and I go to Los Angeles, is that value? Or is that waste? That's waste, right? That's clearly waste. The Biscoff cookies, no, that's value. I would pay for a Biscoff cookie. Soon, yeah. Waiting for baggage at baggage claim, would you pay for that? Does that enhance your experience? No. What you'd really like is to be able to walk off the plane, go to baggage claim, and have your bag sitting there. And not even have to go through everyone else's bags to find it. And to be honest, what I'd really like to be able to do is fly to my nearest local general aviation airport, get on a plane that goes exactly where I want to go, at the exact time I want to go there, and then come back at the exact time I want to come back. Now I understand that that's impossible at this point. But that's value. And when we step back from that value to get to something feasible, we might come up with something entirely different than what we currently have. And so I think it's worthwhile to say, to not limit ourselves to what's feasible, but rather say, what's perfection look like? And then back away from it until we get into feasibility. Yes, sir?
Well, you can pay for it, and then you can have whatever, go wherever you want to go.
Right. And so it's a cost-time trade-off. In the meantime, when I'm looking at it from the lens of lean, I want to talk about which things are value and which things aren't. Can I fix them all today? No. No, I can't. So if I'm waiting to be roomed, is that value? I would say no. Walking from one end of the hospital to the other, we have enough spaghetti diagrams to convince us, that's not value. The nurse is looking for a wheelchair or supplies, I guess it was hunting or gathering. Is that value? No. And while you're there, everything's done, you're just waiting to be discharged. Is that value? No, because it's one of those 7 wastes. Yes, sir, before I go on, I had a question. Go ahead.
What about if you are asked twice before you're given your meds?
That's a great question.
Not value. I'm not paying for it, you fix it a different way.
I could go 2 ways on that. I really like it when it happens. I commend the staff when they do it to me. I'm a great mystery shopper for a hospital because I know what it ought to look like. And I went to both of the local hospitals in my hometown. One got very good scores. The other, the chief operating officer was in my MBA class. And I sent him a note while waiting for my wife's surgery to be completed, explaining why I had reservations. So that it would be time-stamped before anything went wrong. I think that that's one of these patient education things, where we need to educate patients that this is something we do all the time. I'm working with a cancer clinic where the patient comes in every day. Every day they say, "What's your name?" It's like, "What, you don't know me yet?" It's not the point, So I think that's an interesting issue and a challenge. I would agree that it's waste.
Necessary, non-value added.
I think that there is a class of necessary non-value added, and a lot of regulatory stuff ends up in there too. But I think you should own up to that up front. In the meantime, redundancy of identification is good, but if we can come up with something better where we don't have to be redundant because it identifies them precisely the first time, that would be even better. Kern?
John, the reason why it's necessary is for the same reason you stated earlier, that doing something in a routine fashion can be done automatically without us really recognizing it. So a lot of errors that occur in hospitals are not the result of some major mishap where you lose a limb or something like that, but they are the very routine, small things that do not require full consciousness to carry out. And we perform them with such automaticity that we don't even realize that we do them. Think about how many, I take 2 meds in the morning, and unless I put it in a pill box, I have to question myself, did I really take my medicine this morning, or did I remember taking it yesterday, and now that memory is confusing me today whether or not I really took it.
That's
those automatic things that someone what their name is, and that isn't recognized in the curriculum.
That's a skill-based error, and the fix is a mistake-proofing device. Okay? Now, some of you may, a few of you may know Hal Kaplan. He's an AHRQ grantee, and he works on blood transfusions. He also ended up in the hospital. The nurse came in and said, "Are you Mr. Jones?" And he said, "Yes." I mean, he is as far into patient safety as you can get. And when he was in a drug-induced stupor in a hospital, he answered the question about his name wrong. So at this point, a little, yeah, what is your name? Right. That's why that's important. And so when people walk up to me and they say, "What is your name and what is your birthday?" I answer with pleasure. But a lot of the public that are medical consumers don't understand why that's happening. And that's something we've got to work on. Yeah, John?
When they survey past patients who have been in settings like that, where they're in cancer treatment, they're asked every day, what is your name, what is your birthday? You ask them polls. Did you think that was stupid that they kept asking when they knew who you were? And they said no, and maybe feel safe.
And that's where we need to get to, because I have talked to people who aren't quite there yet, and so I think we need to work on those issues. Okay, so after you've identified the value stream, you've identified what value looks like, then you want to identify flow or create flow. And flow is that parts move immediately from one machine to the next uninterrupted. This is right out of a manufacturing book. In healthcare, it would be flowing from one step of the process to the next. Parts and patients should start to approach the speed that any one would take to flow through the factory. Okay, so I struggle because I started out as a manufacturer, and it slips in every once in a while. And I understand that patients aren't products, but I still think some of these ideas are okay. And so when I go to a manufacturer, I say, if you only were going to produce one item in the entire factory, and it's just going to flow front to back as rapidly as possible, how long would it take? That's the baseline for flow, and you want to get down to that. In medicine, it looks more like this. In my local cancer clinic, they realized that a doctor's wife would have an abnormal mammogram and would have a treatment plan within about 48 hours. But that the rest of the public, it would take 3 weeks. And they said to themselves, why is that? Are we comfortable with that? Is it okay for women associated, well known to the healthcare community, to get better treatment than everybody else? They say, well, no, that's not really what we had in mind. And so now if you come to Rome, Georgia, any woman will go from mammogram to treatment plan in 48 hours or less. All the rest of the clinics that can't do that, it's just dried up. Because, you know, my wife is a 10-year survivor, and it took us 3 weeks of waiting and wondering. Because as soon as they call you back to schedule the second mammogram, you know you've got something to worry about. And so, if we could have had that essentially overnight, that would have been only one night of restless sleep instead of 21 days of it. Yes, sir?
There's many clinics, John, by the way, that have the first, if it's clean, right, you get it right away. And if it's negative, you are told to come back. They call it the sleepless night. So we had a process at St. Joe's, very common. We had a process at St. Joe's where when a woman got a mammogram, she knew if it was negative right away. She never had to go to bed that night without it, even if it was a biopsy.
Yeah, so, but that's where flow fits in. So I apologize that I have machine and part here, but that's, you know, that's the quote out of the book. In the meantime, it's very meaningful for patients. Pull. Now I have over here a rack of cans. The idea of pull is that you take something off the bottom and everything rolls down behind it. It means that you don't have to schedule anything. All you do is you pull it off the end. Now, that's a little more difficult in medicine, but not impossible. Some places harder than others. So what we want to have happen is that demand drives production. And finally, perfection, meaning that you do all of those 4 steps over and over and over. And so once you've gotten to the end of it, you go on. And normally speaking, when you eliminate waste, do you know what you find? More waste. And you say, oh my gosh, there's more waste here. Because as you get rid of inventory and waiting and so forth, you find other problems and you fix those problems. So that's the basics of lean. So let's talk about Theta Care. Theta Care has been very active in doing lean. And so their goal was to minimize time, cost, and human labor to complete facility development projects. And their problem was processes not properly evaluated prior to design. Wasteful process equals wasted space and poor design. Lack of early collaboration. I think we've had enough conversation about that, right? The results were expensive, time-consuming designs and build processes, and no more efficient, supportive than the ones they replaced. So you essentially take an old hospital, you transplant it into a new hospital. It's pretty, but it doesn't actually function better. And so they went through and did more upfront collaboration. They used set-based design, which means that they didn't choose one design, that they had a whole series of designs that they looked at for a long period of time and let them kind of compete as they moved forward and combine them together. And they delayed as many design decisions as possible until further down the road. The result was that they had a transformed care delivery process. It was an $18 million project that finished $45,000 under budget, and they had owner-added scope worth about $840,000. So it was completed 3.5 months early, which was 70 additional days of clinical revenue that resulted. So not a bad outcome. And Theta Care's been doing this in their processes as well. They've done a variety of things that are really pretty amazing. St. Joseph's, we've heard a lot about it. That was the old. So, old building. There's the new building. Here's their mock-up room. So they actually tore 2 rooms out to put 1 room in. They started out, it was very rough at first. And everything had a little number by it. And so you could then make comments on it. So here's one that was comments for a light fixture in a bathroom. Lots of people liked it. The ones who didn't said, here's my concern. Virginia Mason. They're in Seattle. And it was interesting. I learned about Virginia Mason many, many years ago when I was talking to an individual who was doing some mistake proofing out there. And he described it as the Boeing diaspora, which means that all of the Boeing lean people were being laid off, and all the local hospitals, Virginia Mason, Swedish, and all the rest, were hiring these people to come in and help them with their processes, which is an interesting strategy. I want to talk to you about flow stations. Anybody familiar with Virginia Mason's flow stations? Okay, so feel free to help me out if you're familiar with that. But essentially you have primary care doctors, and this isn't a hospital setting, this is in a office visit kind of a setting. The primary care doctors were batching the non-visit care at the end of the day. So essentially, they would see patients all day, then when the patient stopped coming, they would go back to their office and they'd have a stack of work to do. And they would work into the into the evening, returning phone calls, answering emails, doing various kinds of correspondence, renewing prescriptions, just all kinds of stuff. The response times were slow and there were late departures from the office. What they decided to do was follow one of the lean techniques, which is to not batch things. That is to say, to have the doctors responding to things in real time. But the doctors were saying, how in the world am I supposed to do that? I mean, it's 2 or 3 hours worth of work every evening. Well, what they did was they tried to make sure that everyone was doing work appropriate for their skills and abilities. And so what they did was they brought in medical assistants. The medical assistants receive and prep the doctor's work, including phone calls. So they're taking phone calls, they're getting all of the material, and they will have it all prepped. So when the doctor steps out of the patient room and is kind of in between patients, they will take 5 minutes. And the medical assistant will say, here's this issue. The doctor will say, here's what we're going to do. The medical assistant will then write it down and implement it. And so the medical assistant will return phone calls. The doctor will be presented with refill prescriptions to sign at that particular moment. And so throughout the day, they're taking little snippets of time, very short bits of time, where all of the setup is done offline by a medical assistant. And so now the doctors are seeing the same number of patients they were before. The feedback or the communication loop with the doctor is much more rapid, and they're getting to go home at a reasonable hour. And they like it very much. Now, what does this have to do with architecture? What it has to do with architecture is that they have to design flow stations. And they didn't know that they were going to need flow stations. So now they've got this process that works really well, but how do you house it? And so here's how they've designed it. So they have a therapeutic path that kind of goes around the outside. That's the kind of on-stage area. And then they have a support path, which is all this area in here. And these little T-shaped things are their flow stations. And so when they have a new facility, they just build the flow station in, everything works great, the doctors love it, the workflow is very, very smooth. The problem that you all have in my estimation, is you don't know that they're going to need flow stations in 10 years. And how do you design a facility so that it's flexible enough so that they can reconfigure it as they go? On the manufacturing side, I've seen lots of factories like this, and it's easy, but it doesn't have to look good because factories don't look good on the inside. I was just at a facility at Edwards Life Science in Draper, Utah, and they have everything on a grid so that all of the power, all of the air, all of the other kinds of facilities that they need are quick release setups so that you can move an assembly line over a weekend and have it up and running in a new location later on. It's absolutely flexible. You can't do that with hospitals. But I think that the direction you need to go needs to take that into account. So, at the end of the day, they're really serious about processes. They use tracking systems and all kinds of stuff to keep track of what's going on in different facilities. The moral of the story, it seems to me, is that it's all about processes. I once spoke with Gordon Forward, who runs Chaparral Steel. He says, we always design our steel mill in terms of where the machines go and how it's going to run, and then we put a building around it. My argument for all of you architects is that it's all about process. And so understanding that process and understanding the trajectory of that process will help you design facilities that support it. So let's see. The flow station process evolved and continues to evolve. Are they satisfied with it? Are they done? If you ask them, they're going to say no. What's it going to be like in 5 years? They're going to tell you, I don't know. I don't know where that leaves you guys. In big trouble, I guess. But it's going to evolve. And so my vote is that you understand that processes are always going to change, and they must change for the better on an ongoing basis. And we need to design buildings that allow that process to occur. And to the extent that you can design things that get in the way of bad behavior and that force people to not do things that they're not supposed to, that's going to benefit them. And that design is one of the most powerful ways to create safety, just like in the table saw example. So that's it for me. I'm happy to answer any questions and go from there. Yes, ma'am.
How do you rank C-class executives in hospitals versus C-class in corporations in terms of accepting these type of, the time constraints and staff training and all the things that come with it?
Well, I don't know, because I don't work with too many C-staff medical people. The ones I do work with, I found to be pretty enlightened. I think a lot of the C-suite understands lean pretty well. And I think that that's a benefit because Martin Hinckley did some research which demonstrated that in almost every case, in every industry that he studied, if you can make it so that things are essentially easier to do, that when you measure how long they take, that time shrinks, the less time it takes, the less errors occur in that process. And so the moral of the story is if you can't figure out a way to make it safer, if you can figure out a way to let people do it faster, you've probably accomplished the same thing. Now, not faster because they're really humping and trying to get it done, but faster because it's simpler, more straightforward, and easy. If you can do that, even if you can't demonstrate it, research suggests that it still may add safety by substantial margins. CEOs have a lot on their plate. Chief officers of all kinds have a lot on their plate. In every case, if we could get them to see it our way, life would be better. I don't know how to fix that. Yes, ma'am.
Getting it fixed up, you know, maybe it's not designing the perfect room, but the best process, because I think among hospitals there's a certain level where those processes are all essentially similar, and then you could design to that process rather than trying to design in the weeds or at the 30,000, you get like some.
Yeah, but I also think you're going to have to do both. I mean, I don't see how you. I think.
At some level, you have some kind of similar concepts. That,
Yeah.
And maybe that's the guidelines.
So you all know more about this than me, but it seems to me that you have to design at multiple levels. And it seems to me that the more participation, the better. And the faster you can make errors, the better.
Right, but you're saying to design around the process, so what I'm suggesting is that there's some level of process that is the same from hospital to hospital. You know, patient comes into the emergency department and gets admitted, and there's certain steps that need to go through, you know, getting registered, getting their med rec done, and figuring out what is the leanest process to get that patient. And of course, yeah, it's contextual, but there is some. It would seem like there is some level where it's very similar amongst from hospital to hospital. You can design to that, or at least have principles that get at that, and then you go down into the weeds based on the individual context of each hospital.
Yeah, and you know, if you look at automobiles, they are not all the same. On the other hand, having been renting cars fastidiously, you know, at significant volume over the past few months doing travel, I noticed there's a lot about them that's the same. I mean, you know, I know where the radio is. I know where the speedometer is. I know that the gas and the brake are not going to be on opposite sides. Are they different? They're tremendously different. and there are some that I like better than others. But there are also some commonalities, and you know, maybe the next thing to look at is, what are those commonalities? What does everybody agree on? And, or what can they agree on, and move on from there. So I think standardization is going to be good, but I also think continuous improvement is going to be good. How do you have both of those at the same time? Yes, sir.
Could you or others in the room talk about the relationship between lean and safety? Because that's one of the big breakthroughs that we had at St. Louis about is lean, are the principles of lean the same as principles of safety?
If I were going to draw a Venn diagram, they would be significantly overlapped, but not entirely overlapped. I think that lean will deliver lots and lots of safety. Standard work is going to bring safety. Reducing things to being simple instead of complex is going to bring safety. Making things flow faster is going to bring safety.
Reducing steps by value.
Right. So reducing the wastes is going to make things safer. So I think that there are occasions where lean will just deliver financial results as opposed to safety, but generally speaking, I think that you'll get a lot of safety, you know, maybe 90–95% of what you do will also enhance safety. Yes, sir.
I'll just add to what you just said. If you think about lean and creating value from a customer perspective, and if value is defined as safety from a customer, then safety is a subset of what lean thinking is. Because as a consumer or a patient, I'm coming to a hospital where safety is a given. I don't think safety is a choice. In airlines, you assume once I take off, I land. You know, I mean, I don't think it's assumed. They don't plan that, you know, this trip will be safer than the other trip. The landing may be different. The flight experience may be sometimes more turbulent and less turbulent, but safety is baked in. And if what lean thinking really forces you is, how do I create value from a customer perspective? And in healthcare, if the customer is your patient, then safety is a must. You know, so I don't think they go, you know, means they're not mutually exclusive. I think safety is built as any other value. The way I look at it is, how do I provide cost-effective care in the safest manner with an outstanding experience, and then in the right locus of care. And that's what it comes down to, you know, is how do I provide that care in the most cost-effective and safest fashion. And you have to build both together to get where you want to. And lean is just a philosophy or a tool. I just wanted to kind of echo, you know.
Okay, so our time is just about up. I'm willing to continue to take questions, but I remembered something I wanted to tell you all. I have 150 examples from medical healthcare kind of applications. I'm also working on a new version of the book that has architecture, engineering, and construction examples of mistake proofing. So we've been talking about mistake proofing healthcare systems, but if you happen to have things in your architecture practice that you do to mistake proof, please send those to jgrout@berry.edu. Because we're going to collect those and try and create an architecture, engineering, and construction book very similar to the one we did for healthcare.
Great.
One more question. Was there a question there? Yes, ma'am.
I had a comment, a question. The term safety has been used ubiquitously today, and that's a good thing. And I think all of us, though, think of patient safety. And I think it's important, and I asked the group to, when you think of safety, think of occupational safety, employee safety, along with patient safety, because there is a linkage that you can't separate. And so when you think of these tools to use, and you think of safety within the healthcare environment, you have a healthy worker, you're going to have better quality of care. You have a safer worker, you're going to have better quality of care and safer patients as well.
The evidence to the contrary lies in aviation. In aviation, passengers are very, very safe. Maintenance technicians, it's one of the most dangerous jobs out there. And we shouldn't make that same mistake with healthcare. So I agree with your sentiment, but if you're not careful and include both, I mean, that's why your comment is important, is if you don't include both, you won't get both. And we should include both. Pardon me?
I said, and the environment, as healthcare providers, we should be safe to the environment as well.
Right. So, thank you very much.